everyone for the invite to talk today. So we're a pretty small group, and I really want this to be more intimate and sort of set up in a Q&A setting. I think maybe to start, I have a few slides to introduce myself, but I would also really like to know a little bit about everyone who joined us today. Just sort of a little bit about your background, what your specialty is, and what is your practice focus on. So if everyone could just do a brief introduction, that would be great.
Ashley, would you like to ask specific people?
Oh, well, why don't you start, Dr. Lemma?
Okay. Well, obviously, my name is Abasalam Lama. I'm an assistant professor of urology in the Columbus Hospital. We are actually the first ones to start training in urology fellowship in Ethiopia. We have the oldest urology service in the country, and currently we're training close to 30 residents in urology. For now, we really don't have any field of subspecialty because the number of urologists in our country is quite limited. I think right now we probably have about 50 for 100 million people. So we mostly do general urology, but we obviously have a specific pattern of diseases, and one of those patterns of diseases is prostate cancer. Most of our patients, like I told you through our email, most of our patients come with either locally advanced or metastatic prostate cancer, and we usually deal with those. We don't do any radical prostatectomies, and our oncology team has recently started giving radiotherapy for prostate cancer. So I think that's it from me. Maybe the rest of the audience can participate. Dr. Fakadu, are you there? We can start with the chief residents.
So are most of the folks in this call urology residents?
Yes, so far from what I can see, we have one senior urology consultant. Dr. Masai is one of our instructors, and one junior urologist, and the rest of our audience is going to be mostly urology residents who are going to be mostly from our university.
Okay, great.
And a few oncology residents too.
Sounds good. So I'll
hello everybody. Hello Dr. Yu. My name is Samer. I'm from Egypt. I'm currently intern physician. I graduated med school a year ago. I'm highly interested in urology, and actually I'm impressed by the work you're doing at IVU. Actually, I met Ashley before, and I expressed my interest to do volunteer work with you, if that's possible. And I'd like to thank everybody for holding those webinars.
Great, thank you, Samer, for introducing yourself. So I'll get started. I'll talk a little bit about who I am and what I hope to achieve today in the next hour that we spend together. So a little bit about my background. You can see here, this is a map, and I'll tell you where I kind of started off in. If you see up there and where I put a little star, that's actually where I grew up and did the majority of my training, which is actually in Canada. And I went to medical school and I did residency in urology up there. And then after I finished residency, I wanted to specialize in urologic oncology, so only seeing cancer patients from a surgical perspective. So I did 2 years of additional training, which is called a fellowship, in Massachusetts, in  at some of the Harvard affiliated hospitals. And then after that, I traveled down to Florida, which is where I work now at the Moffitt Cancer Center, which is affiliated with the University of South Florida. And I'm an assistant professor in urologic oncology there. And then as you can see on the map there, I looked up a little bit where you guys are all at in Ethiopia, which is really, on the other side of the world. And I did want to mention that I had a little bit of experience in Africa, though very brief. When I was in residency, I spent 2 weeks with one of my mentors, and we traveled to Rwanda and did a little bit of work in pediatric urology there. So here's a photo with me and my mentor, Dr. Mohammed El-Sherbini, and we were doing a pediatric urology case with some of the local residents there. And my time there was very, very brief. It was only 2 weeks. And my attending brought me there to help with teaching some of the junior residents locally. But I think overall, what I got from that experience was that I probably learned a lot more than I was able to teach. And I think from that experience, I realized, well, urology is practiced so differently in different places of the world. Even between where I trained in Canada and where I work now in the US, there are some minor differences in how things are practiced depending on, your patient type, patient profile, your resources that you have. So obviously the way that you practice urology in your community is going to be extremely different from what I see on a day-to-day basis. So the way I kind of prepared this talk was that I wanted to kind of focus a little bit on what I see on a day-to-day basis, but really feel free to interrupt me at any point, and I'd be happy to, pivot this to something that's a little bit more useful and applicable to your practice. So the first half of the talk, we're going to talk about the management of clinically localized prostate cancer. So this is much earlier stage than what a lot of the patients present with in your practice by the sound of it. So these are patients who have no signs of disease spread to sites of metastases or even locally. So they can be resected surgically. And then for the second half of my talk, I thought I'd discuss radical prostatectomy. I was a bit surprised when Dr. Lemma said that this was something that you don't do that much in your practice. And I'm sure that might be because of the patient population you see. Though this is what I do on a day-to-day basis as a urologic surgeon. So to start, these are our guidelines on the management of localized prostate cancer. The treatment options really depends on two things: risk stratification and the patient's life expectancy. So as you all probably know, risk stratification of localized prostate cancer depends on the PSA, the clinical stage, and the Gleason score on biopsy. So starting with low-risk prostate cancer, which I'm sure, as you know, is defined as PSA of less than 10, a Gleason 6 on biopsy, or otherwise known as grade group 1, and a clinical stage of T1 or T2A. In these patients, the risk of cancer spreading or metastasis is extremely low. So typically we do not recommend any kind of additional imaging workup like CT or MRI or bone scan, because the chance of finding metastatic disease is so low that it would be a waste of resources and unnecessary. This is a huge part of what we see in the US, actually. A lot of times patients undergo screening for prostate cancer, so their disease is found really, really at early stage, and we find a lot of these very low risk prostate cancers that may actually never need any treatment in the patient's lifetime. So we tend to actually watch these cases with surveillance. In only select cases when the patients have a higher risk of progression, that we would even consider surgery or radiation therapy. And there's been a lot of studies and data looking at whether, studying surveillance. They looked at the cancer control outcomes, and they looked at functional and quality of life outcomes. And ultimately, what we know about surveillance for low-risk prostate cancer is that, firstly, surveillance is safe. So if you keep a close eye on the patient, even with some low-grade prostate cancer, we know that the risk of missing the boat to treat and potentially cure the disease is very, very low. We also know that when we follow the patients long enough, about 1 out of 3 men will probably progress and will need treatment at some point in their lifetime. And usually the trigger for treatment involves a rise in the PSA on the follow-up, or maybe there's changes on their rectal exam or changes on an MRI. Or sometimes when we repeat the biopsy, we see higher grade disease. So even though 1 out of 3 men will need treatment at some point on surveillance, we know that 2 out of 3 men may actually never need treatment in their lifetime. And therefore, we avoid some of the morbidities like incontinence and erectile dysfunction that we see with treatment. While on surveillance, some men get very anxious knowing they have cancer, even though the chance of progression is so low. So we know from these large studies that even up to 5% of men will actually end up undergoing treatment for low-risk disease, mostly because of, quote unquote, anxiety or not wanting to live with the knowledge that they have a little bit of cancer in their prostate. However, overall, we know that surveillance is associated with a better quality of life compared to surgery or radiation. And that's what we favor for men with low-risk cancer. So how is surveillance done? Usually we check the PSA every 6 months, do a rectal exam every 6 months or every year. Typically we'll repeat a biopsy after diagnosis, sometime around 1 year after, with or without the use of prostate MRI. I put a note there that patients with a lower life expectancy don't actually need surveillance, especially when they have low-risk cancer, because we know the chance of them progressing or becoming symptomatic or dying of the disease is extremely low. So oftentimes we do a less vigorous observation type approach in those cases. So intermediate risk prostate cancer is another big category that I see in my day-to-day practice. These are men who have slightly more, very slightly more aggressive disease, where if they're young enough and we have long enough of a follow-up, we typically do recommend treatment because it can progress to a more serious situation down the line. The intermediate risk category is divided into favorable and unfavorable, depending on the biopsy features, the clinical stage, and the PSA. Generally, for people with more unfavorable features, we do recommend some sort of staging scan, either MRI, CT scan, or bone scan. And we do a lot of MRI for local staging in this population. The treatment usually involves more traditionally surgery or radiation. Focal therapy is also an option, which I'm not going to talk too much about, but it can be an option in select cases. And then I did put surveillance there as an option, mostly for people who have a shorter life expectancy or lower volume favorable disease. So if we compare surgery, radiation, or just monitoring, we know that in this category, the risk of patients dying from prostate cancer is, if you look on the top graph there, essentially close to 0. And if you compare surgery versus radiation, the blue and red lines, there isn't much difference in oncologic control between these two types of treatments. So a lot of times our patients come They meet me and they meet a radiation oncologist, and we talk to them about both treatment options and the side effects of that. And our patients will typically choose one option or the other based on their own personal preference. So the high-risk prostate cancer, this is probably a population that you see a little bit more. Though high risk here, I'm really talking more about disease that is still localized to the prostate, that is surgically resectable. We know that when we have a high-risk patient, so PSA greater than 20, a Gleason score of 8, 9, or 10, or higher clinical stage, they definitely should undergo a metastatic workup, usually with cross-sectional imaging such as MRI or CT scan, or a bone and a bone scan to look for bony metastases. There is growing interest of using different types of PET scans that are more specific to prostate cancer, though that is something that is still being researched and not routinely used depending on availability here in the US. So I'd say the vast majority of my patients will probably undergo an MRI where we can look at the prostate and get some idea of the local staging, as well as the lymph nodes in the pelvis, and they get a bone scan to look for distant metastases. So in patients with high-risk prostate cancer, we know that their chance of progressing even after treatment can be pretty high. Here in the US, I think a lot of these patients will undergo either surgery or radiation. What I tell my patients who really want to have surgery for this disease at this stage is that a lot of times they will need additional radiation, when maybe hormone therapy after surgery, because there's a very high chance of having positive surgical margins, detectable PSA after surgery. A lot of these patients undergo radiation also, and generally the radiation oncologist will give them higher doses and more prolonged course with several years of ADT or androgen deprivation therapy, because we know that this is a more aggressive disease and the chance of the disease coming back is a lot higher. Sometimes in men with a shorter life expectancy, less than 5 years, for example, you can consider observation, especially if they have a lot of comorbidities already, or you can consider treating them with hormone therapy alone. So I'm going to pause there and maybe open the floor to discussion about any kind of cases that you might want to talk to me about, cases that you see on a day-to-day basis. I'm curious as to whether or not what I just talked about is even applicable to your practice.
Okay, thank you. I guess from what you discussed right now, we don't really have any screening program with PSA for now. Like I said, it's the healthcare service in our country is quite limited, and specialized care like urology is not available everywhere. Even in our practice, our biopsies are usually limited, and we usually do this, finger-guided biopsies, for example. We don't routinely do ultrasound-guided biopsies. The multi-parametric MRI is not available for free, at least, so it's quite expensive for patients. So, and one, I think, very big factor is the patient understanding. I assume that in the US, you can, talk to your patient and convince him that he still has a cancer which is not going to progress. We find it very difficult in our setup to discuss with our patients, so actually, especially these elderly people who are not educated. You can't even mention the word cancer around them. Sometimes the family members who bring them to you, really don't want the family, the patient to know that he has something like that. They're very sensitive people. So it takes really a lot of effort to convince some patients to stay on, for example, the surveillance or just, observation. So these are some of the challenges. And usually we only do this MP-MRI if we find negative biopsies on the initial finger-guided biopsy, so that we can actually target our biopsy relative to the location of the lesion. And these are the cases that we rarely find because we don't necessarily screen all patients for prostate cancer. Rather, when they come complaining of lower urinary tract symptoms, we, based on the rectal exam finding, we may do a PSA and we take it from there. So routine screening is, we usually argue with our older consultants that we don't need routine screening, because if we start picking up more tumors, it's going to basically be a load on the healthcare system, because we have to do biopsies, we have to do radical prostatectomies, which we don't really have the setup for sometimes and the training for.
Mm. So how do most patients present in your practice when they're symptomatic?
Yes, patients who present with prostate cancer, usually they're diagnosed after they present with either lower tract symptoms or metastasis, or when they have acute retention, and then we find out their PSA is elevated.
And then in those cases, you do like a metastatic workup with CT and bone scan?
We do a CT, we do a biopsy.
Okay. And then if there's no signs of metastases, what do you do in that circumstance? Mostly radiation?
We do send them to radiation. That again depends on the PSA and the Gleason score that we find. So usually we send them to radiation, or if we can convince the patient, we just put them on follow-up.
So what kind of patients would you do follow-up for? The low-risk cancers, or like a low volume intermediate risk?
Usually for low-risk cancers.
Okay. And how do you follow them?
Most of the time we follow them with PSA, and patients who can actually afford to do a scan, we may do like cross-sectional imaging, either a CT or an MRI every either 6 months or 1 year. Biopsy, we find that, like I told you, we do finger-guided biopsy, so the yield is not going to be so nice since we don't do it ultrasound-guided.
Okay. And when you do a finger-guided biopsy, are you still able to do a 12-core template?
No, not all the time. Usually, most of our patients who require a biopsy, they have clearly suspicious lesions, or on either lobe or all of the prostate is hard and irregular. So usually, maybe we take about 6 or maybe 10 at most.
Okay, it's very interesting and very different from what I see on a day-to-day basis. So I'll move on to the second part of the talk. So you mentioned that you don't do a lot of radical prostatectomies. So this is actually what I do on a day-to-day basis as a urologic surgeon. So I thought it'd be interesting to talk a little bit about that. Most of the time, prostatectomies are done robotically in North America. So you see the bottom here, this is what our OR setup often looks like. You have the patient on the table with this robot and some of the arms that have been inserted through trocars, kind of like laparoscopy. And then the surgeon sits on the side here, manipulating the console, which in turn moves the robot arms, and we do our dissection that way. With that being said, open prostatectomy is definitely still performed in certain centers and by certain surgeons who have that expertise. And And that's something that I've done a little bit also in the past. So for the next few slides, all these images are taken from, our classic urology textbooks, Campbell's and Hinman's. And I thought we could go over some of the steps of a prostatectomy, the pre-op and post-op expectations. So usually when I see a patient who is a surgical candidate for prostate cancer and they meet in clinic, we go over a lot of counseling for the surgery. We talk about the benefits of surgery, which is a lot of what we talked about in the last half an hour, and the indications for surgery. And then once we determine that someone can be a candidate, we talk about the risks of the operation. So I tell them about the early perioperative risks, like things like bleeding, infection from the surgery, the risk of injury to the bowel, the rectum, ureters, major vessels, or any other kind of surrounding organs, which generally for this surgery is on the lower side. There's also a risk of perioperative cardiopulmonary risks, like getting a heart attack or a stroke or a pulmonary embolism from the surgical stress. Though generally, because the patients that we operate on for prostate cancer tend to be younger and healthier, because those are the people who benefit the most from surgery, the risk of this is low. And the risk of dying from this operation is very uncommon. We talk about some of the late perioperative risk of surgery, like developing a urine leak from the vesicoureteral anastomosis. We talk about developing an anastomotic stricture, hernia from the incision sites, or bowel obstruction, like with any major abdominal surgery. And then we focus a lot of our discussion on long-term functional outcomes like urinary incontinence and sexual dysfunction. Generally, I tell my patients that after the surgery, everybody's going to be incontinent for a little while, and it can take weeks or sometimes months for that continence to return. Overall, in the long term, so if we look at 1 year after surgery, generally the continence rates are very good. The risk of being incontinent or having life-altering continence where they're still wearing pads or diapers or dependent on those things is quite low, but it takes some time to get there, and the recovery will take some time. As for sexual dysfunction, that depends on a wide variety of factors. Generally, the patient's baseline sexual function status is a good predictor of what they're going to be like after surgery. And also in patients who are candidates for nerve-sparing surgery, so if they have more favorable disease like intermediate risk or a very localized high risk with no evidence of tumor extending into the neurovascular bundles, then we'll generally try to perform nerve preservation to help with achieving sexual function after surgery. But even in the best candidates who have bilateral nerve sparing surgery, it can still take some time before return of sexual function. So we're going to talk mostly about open prostatectomy here. So to start, the patient is placed in a supine position, and we usually flex the bed to open up the infraumbilical space, a little bit like a cystectomy. We'll make a lower midline vertical incision, carry it from the umbilicus down to the pubis, and we split the rectus muscles in the midline, and then we enter the extraperitoneal space. So usually you shouldn't see any bowel. You don't need to get into the peritoneum for this surgery. After we develop the extraperitoneal space, usually we'll put some sort of retractor there, self-retaining retractor like a Buckwalter or a Balfour. Here's an image of what you see after you develop this space. This is the prostate. This is the bladder. There's the pubis, and here's would be the umbilicus. Typically, you see a lot of fat in this area, and some of the more superficial branches of the DVC. So we usually start by opening the endopelvic fascia, and you can do that with meds or cautery. And then usually you could either tie off some of these superficial branches or just cauterize them. And then next, after you open the endopelvic fascia, usually you're able to identify the DVC or the deep venous complex. So this is an area that bleeds a lot. It's really important to tie off these vessels well. Usually put like several figure-of-8 sutures here. And it's important to just be careful not to go too deep and go into the urethra at that level. Here's an image in a live patient. Here's your pubic bone. This is your prostate. The endopelvic fascia has been open. And then you want to control the DVC with some sutures and then divide it. So once the DVC is divided, sometimes you have to put some additional sutures for hemostasis, and then you can divide the urethra next. It's important to have a Foley catheter in while you do the surgery so it can help you identify the urethra. At this point, once the urethra is divided, typically it's a good time to put in a few sutures into the stump so that because it can be a little more tricky to access it afterwards. I'll usually, from my experience, we'll usually put in 6 simple interrupted sutures, and you kind of clip these on to some hemostats so that you can use it later. And then from the apex, you kind of do your posterior dissection, take it off the rectum, and then you'll encounter the pedicles bilaterally here. Generally, clipping them is the best way to get hemostasis. And then you also have the neurovascular bundles here that you can peel off the prostate if you want to do a nerve preserving surgery. As you move towards the base of the prostate, usually you encounter the seminal vesicles here, and they actually can be quite vascular as well. You'll want to clip off some of the vessels that go towards the seminal vesicles. And usually surgical clips are a good way to control that as well. So once you have the posterior and lateral dissections done, you open the bladder neck, and then the prostate is usually removed at this point. Once you open the bladder neck, you have an image right here. You want to make sure you identify the ureteric orifices to make sure that those are not injured, especially if they're very close to the bladder neck. Sometimes they can get caught. Some people like to use different types of dye like methylene blue or indigo carmine to help identify the orifices. So once you make sure those are protected, you may want to reconstruct the bladder neck if it is very wide. There's different ways to do this. You can either kind of just do a suture like this to kind of narrow your bladder neck, or sometimes some people like to put these sutures near where the ureteric orifices so that you can kind of push them a little bit more deeper into the bladder and away from the anastomosis. So once you have a nice small bladder neck, that's when you want to bring those urethral sutures that we had earlier and then bring them to the bladder neck so you can make these interrupted sutures. And you always want to make sure that you do your anastomosis over a Foley catheter. Here you have the DVC all tied off already. So in terms of the postoperative care, usually we leave the Foley catheter for about 1 or 2 weeks to allow the anastomosis to heal. It's a good idea to leave a surgical drain for at least a day or 2. And if you have a higher output and you're suspecting a urine leak from the anastomosis, you can send the drain fluid for creatinine. Usually after a day, if I do leave a drain, I take it out if there's no signs of a leak. Before removing the catheter, you can consider doing a retrograde cystogram to look for an anastomotic leak. And typically, if there is a small leak, most of these cases are managed conservatively, and we just leave the catheter for a couple more weeks and they tend to heal. We didn't talk too much about it in the with the diagrams, but for the higher risk cancers, you probably want to do a pelvic lymph node dissection and remove the lymph nodes along the external and internal iliacs, mostly for staging and risk stratification. Do you have any questions or anything else that you want to discuss? So that's sort of the end of my talk, but I'd love to talk more about some of the cases that you see or any kind of challenging cases that you want to discuss.
Okay, thank you, Dr. Yu. My questions is just some practical things,
Yeah.
especially when it comes to open radical prostatectomy. It really depends on volume. That your outcome really does depend on volume, and more common than localized prostate cancer, we do have localized bladder cancer.
Okay.
We have, especially in our hospital, since it's the referral center for the whole country. So we do have large tumors, muscle invasive bladder cancer. And how do you see what would this be a good entry point into doing radical prostatectomies if somebody has adequate exposure for radical cystectomy?
I think so. I mean, at the end of the day, you have to start somewhere. And I absolutely think, if you do a lot of radical cystectomies, you'd be familiar with a lot of the anatomy down there. And you kind of do a prostatectomy with your cystectomy. A lot of the steps are very, very similar. I think the most challenging part that would be different is really the incision at the bladder neck and the anastomosis. Some things to consider when you do a prostatectomy, you really want, so distal to the apex, if you can preserve as much of the urethra as possible, that's going to help you later with the anastomosis. And there's some people who think that that may help also with continence afterwards. So I know that cystectomies, I do a lot of open cystectomies as well. They can get a little bit bloody. Same with prostatectomies. I think just having really good dissection of the apex, isolate your DVC, and then try to preserve as much of the distal urethra as possible can be helpful. It's a little bit different from cystectomies in terms of posterior dissection as well. At least for my cystectomies, I go from bladder down to apex, whereas for prostatectomies, a lot of people prefer to go from apex towards bladder. And I do think that you have a better visualization of the rectum that way. In terms of the bladder neck, I think that's another part that can be quite challenging because there isn't a great plane. It's really hard to identify where does the prostate start and where does the bladder end. If you put a big Foley balloon in the bladder, like a 30 cc balloon or a 20 cc balloon, and you tug on it, or even a 10 cc, if you tug on it, that can help you identify where the bladder ends and the prostate starts. And then in terms of making that incision, it's a balance between, you want your bladder neck to be as small as possible, so you don't have to do as much reconstruction, but you also don't want to leave prostate behind. And that's something that just comes with doing more cases and getting more experience and following up on your pathology and seeing what your margins look like. I would say from an oncologic standpoint, maybe it's safer to err a little bit more on the bladder side. When you start, you can always try to reconstruct it. Whereas if you leave cancer behind, then it kind of, defeats the purpose of the surgery. But I think pulling on the bladder, pulling on the Foley balloon, that can help you identify it. Make sure you look for the ureters afterwards. If you have trouble identifying it, sometimes you can use a 5 French open-ended stent. And that can also help. If your ureteric orifice is really close to your bladder neck, it's definitely worth putting a few sutures there. I usually put in a figure of 8. And if you put it right at the level of the bladder neck, it kind of pinches the bladder neck a little bit, and that UO just kind of gets pushed in. So that will help, because if your UO is really, really close to your bladder neck, number one, you can catch it when you do your anastomosis. And also sometimes you can have urine leak directly from the UO into the anastomosis instead of going into the Foley catheter. And then afterwards, I think the setup is probably one of the most important things. You want to put in those anastomotic sutures on the urethra before you do the bladder neck, so you're kind of prepared and ready. Sometimes those sutures can get a little bit tangled. Some people like to put a little label on their hemostats and just label, like the posterior and the mid and the anterior on the right and left side. So that kind of helps you keep track of where that needs to go on the bladder end. So those are some of the things that I can think of at the top of my head, but ultimately, I think try just to get good exposure. And, with your cystectomy background, I think, you definitely have, the technique, I think, to do, and it's just a matter of kind of diving in and do it when you need to.
How about metastatic prostate cancer? How do you manage these patients, and what's really your cutoff point to determine somebody is having castration resistance? Sometimes, for example, just yesterday, I saw a patient who we did a bilateral orchidectomy for metastatic prostate cancer. He came with, lower urinary tract symptoms and back pain with, vertebral metastasis. His initial prostate PSA was 2,250. Sometimes we see people that high.
Mm-hmm.
And over a period of, I think, about 8 months, it's dropped down to about 15. Then started going back up again, up to 30, 35 or something.
Yeah.
But now he has, castrate level testosterone, not symptomatic. These are some of the patients we find like this. Most of our patients, even though the PSA is not always this high, usually we get PSA above 100 most of the time.
Yeah.
So what would you classify as, what would you recommend for such a patient?
Yeah, that's a great question. I don't see a whole lot of those patients in my practice. We do see patients who present with metastases. Without a doubt, that's a big part of some of our medical oncologists' practice. I think in the case that you described, when in someone who is without a doubt castrated, we don't do a lot of surgical castration. Mostly the patients don't want it, and they rather have their Lupron injection every 3 months. But in your case, with surgical castration, you can improve on that. One thing that we will check often is the testosterone level, because on injections, compliance can sometimes become an issue. So sometimes you see the PSA go up, but they're actually not castrate level because they missed, their appointment and didn't get their Lupron. But with surgical castration, there's nothing that you can do better. So when you see the PSA rising like that, I think the patient is definitely meets the definition for castrate resistance, unfortunately. So they may need to progress to some other form of therapy, whether it's abiraterone, enzalutamide, docetaxel, some second line therapy. Our medical oncologists see a lot of those patients. Well, if there aren't any more questions, just want to say thank you so much for having me today. The discussions I thought were, really great and really interesting. And oh, is that a raised hand? I'm not sure. Dr. Habtamu?
Yeah, okay, thank you, Dr. Yu. So it was a nice lecture that we attended. So my question is that on your outcome of the patient is, you do this radical prostatectomy routinely. So how is the outcome, like the perioperative mortality and also the long-term outcome? Is there any objective study done in your center that can show us this outcome of the prostatectomy? Thank you.
Yeah, absolutely. So in terms of oncologic outcome, I think that really depends most on their initial risk category. So with patients with intermediate risk cancer, vast majority of time after surgery, their PSA is undetectable. And we know that generally their recurrence rates are relatively low. We follow them with PSA check every 6 months. And if they're a true intermediate risk on their final pathology, generally they don't need any additional treatment and we just follow them with the PSA. If they do have biochemical recurrence, so the PSA becomes detectable after surgery, usually refer them to a radiation oncologist for salvage radiation combined with 6 months of ADT. And the more high-risk patients, we know that their recurrence rate can be very high, can be higher than 50%. Sometimes their PSA is detectable right after surgery. Sometimes it's detectable several months after surgery or 1 year after surgery. At our center, we don't tend to do too much adjuvant radiation, meaning treat them with radiation before the PSA is detectable after surgery. So kind of like prophylactically, because you know that their recurrence rate is so high. With PSA, which we know is such a sensitive marker, I think the trend is to monitor the PSA, and if it ever does rise, to do salvage treatment with radiation only when the PSA becomes detectable. So with the high-risk patients, that can be a pretty high rate. One thing I tell my patients a lot is just because the PSA is detectable after surgery, it doesn't mean they're going to die of prostate cancer. Just because they have biochemical recurrence, that's not a good surrogate for cancer mortality. It just means that they do need additional treatment to help reduce that risk. But a lot of these guys have just much earlier stage disease than probably what you see. In terms of surgical complications, it's really quite uncommon, actually. It's quite rare that people need transfusions or, antibiotics for infections. I would say overall, definitely less than 10%, probably less than 5%. In terms of more serious complications like, injury to the rectum, like, knock on wood, luckily I haven't had anyone, but I'm, pretty early in my career and practice. And, as you become more and more high volume, anything can happen, but it's a pretty rare complication. From a urine leaks, generally, I haven't had any major leaks, and I've never seen anybody that needed to be taken back for surgical repair in my training or my practice. From a continence standpoint, and that's probably something that bothers the patients the most, generally they return function around 6 weeks to 3 months. And overall, in the long term, I haven't had too many patients, again, knock on wood, needing additional surgery to repair their incontinence. it just takes some time for it to return. And then sexual function, though, that it can be a lot more variable. I tell my patients that it could really come down to 50-50. At the end of the day, it really depends on, how aggressive the disease is, were we able to do nerve sparing surgery, what was their baseline function. But I do think sexual function is impacted a lot of the time. And I'm very honest with them about that so that they have realistic expectations after surgery.
Well, if those are all the questions, thank you so much, Dr. Yu, for your time, and Dr. Lima for helping coordinate this talk.
Yeah, thank you, Ashley, for organizing this and IVUmed. I think it's great that we're able to do these type of lectures when we, live so far away, but we're still able to interact with our global colleagues. And it's really a great opportunity for me to learn and hear about your practice as well. So I really appreciate that. And thank you, Dr. Lemma, for helping me understand what your practice is like. And even before the lecture, thank you for answering those questions. It was super helpful. And I'd be, happy and excited to do this again sometime. And I think, understanding a little bit more about what some of your patients are like can also help me prepare these a little bit better and really tailor it more to your needs as well.
Thank you, Dr. Yu, for giving us the time for this presentation.
All right. Bye, everyone.
Okay, bye.